Leah is an emerging researcher in ageing and the use of large administrative data sets within and outside Stats New Zealand IDI. Her main research interests are patterns of healthcare use and maintenance of independence in later life. So, Leah Palapar, welcome to the room.
Thanks, Nari. Hi, everyone. I'm Leah Palapar. I'm a research fellow from the Department of General Practice and Primary Care at the University of Auckland. And today I want to share an idea about identifying older people's transition to ARC using data within the IDI. I'm not going to spend a lot of time in the background, but I do want to say that for us to understand the inequities, predictors, and outcomes of different groups of older people as they use aged care services, we need to be able to accurately estimate when they transition from community-based services to age residential care. So outside the IDI, the CCPS, or the Contracted Care Payment System, or the Payment Subsidy data set for short, is an important data source. So if you look to the graph to the right, that's from a recent study which looked at different data sources as an estimate, for estimating ARC placement. So in this study, the pink block behind there is the payment subsidy. So in this study, they found that 69% of ARC placements can be identified from the CCPS alone. And when you add the location of death and hospitalization data, you can increase that to 89%. Unfortunately, we don't have the CCPS within the IDI. And so others have used the address notification table. So this is a table that tells you whether a person changes their address from one to another. So these are all recorded within the IDI. So this is one of the signals that is used to determine whether a person has moved from community to age residential care. So what was our idea? So we wanted to look within the IDI for a way to identify age residential care placements, but with interRAI as the main source, main data source, rather than the address notification table. So what we're going to do is to look at the population age 75 plus in the 2013 census, and then we'll look at all of their assessments over the 10-year period to determine whether they're in ARC or in the community, or they transition from ARC to the community. And then what we hope to do is to compare the estimates that we get from this method to the estimates that are, thank you, we'll compare the estimates that we get from this method to the estimates that can be gathered from other methods, including the Social Wellbeing Agency's change of address method. So this is really the meat of the presentation. I want to talk about our proposed method of identifying ARC placements. So in the IDI, the interRAI dataset is a long dataset. So every entry is one assessment. And so ideally, well, theoretically, you can tell where the person is at that assessment. And so that's the first step. And we'll talk about that because that's a bigger algorithm after that. So at each assessment, we want to assign a residence code. And here we say it's just A or for in ARC and C in community. And then once we have that assessment, that entry per assessment, we're going to look at them at the person level. So that's step 2. So for example, a person has 2 assessments. Both of them are AA. So that means that this person throughout the 10-year period was already in ARC. And if you go here, so this is an example of a person with CCC. So CCC is in community throughout. So what we're actually looking for are these people, the ones that start with a C. So we know they've got an HC or a CA. And then they move from an HC or a CA into an LTCF. And the next step, the third step, is to merge and clean the data set with the mortality data. So we have to do this because the interRAI data is all assessments, right? But only a small proportion of older people have assessments, have interRAI assessments. So when we connect that with the census data set, we'll have a huge proportion of people with no assessment, so we can't determine where they are. So using the mortality data, we'll be able to tell whether they were alive for a certain period and not assessed, or they're still not assessed, or they died and were not assessed before their death. So this is an expansion of what I was saying as the step one. So I know there's a lot of boxes in there, but I like you to start here at the start. So there's actually just 4 variables in there. So this variable is care level, the triangle. The second variable is the type of assessment. You've got this one and that one. You've got the location of assessment, which are these 4. And this one is the last, the usual residence of the person. That's also included in the interRAI questionnaire. So what we found in our preliminary work is that 50%, half of the population of the assessments that we found, fall in this direct path from care level to going to ARC. So we all know for sure that they're in ARC. And another maybe 40% is in this direct path from community assessment, HCRPC, going into the community. So we know for sure that they're in the community. Some people don't have a care level specified, but are an LTC assessment. So we know that they will go here. But there's maybe small-ish proportion, 10%, around 10% of the assessments are made in the hospital. So we can't really tell whether these are whether these people are in the community when they were assessed or in ARC. And so we use that usual residence variable here to tell whether they're possibly in the community or in ARC or possibly in ARC. So I guess one of my questions for the group is that what do you think are other variables that will be useful for us to add? Because of course, if we want an accurate estimate down the line, we want an accurate estimate even here at the top. So yeah, so we're keen to get your ideas, and if you know of any possible pitfalls of our method or whatever, maybe if it's a good idea to merge our method with the change in address method, then that'll be cool too. Thanks, everyone.
Okay, you didn't. Did you also have a look at the ministry's proportion of people in ARC?
No, not yet.
Not yet.
Not yet.
Okay. Okay, questions?
Yes.
Oh.
I'm not sure whether Farm Starter is in the IDI at the moment.
Yes, I think it is.
Because if my understanding is correct of the system, and it may not be, the dispenser changes when people go into ARC, because suddenly they are reviewed by the facility, and through the facility the medications are given rather than through their GP, and so you may find a change in there.
Oh, thank you. That's really helpful. We're gonna definitely.
But check it out. I'm not sure that my hypothesis is correct here.
Yeah, we're definitely gonna check that out and add that to this algorithm here. Yeah.
You can ask Amy Chen. She's not here because she's very familiar with farms data set. So check that out.
Oh, I will.
No questions online. A very quiet lot online. Let's go. Oh, who's got the? Gary.
So before I ask the question, remind me the goal of the exercise?
So we want to tell, because for example, we know we've been talking about this earlier. It's been said that Maori have fewer Maori go to age residential care than non-Maori, right? So they tend to have bigger bigger use of family care, or not use of family care, but informal care and community-based care. And so one of the reasons why we want to ask about that transition is to be able to estimate, so who are the people who are using healthcare, community-based care versus ARC? So what's that balance? Because we can just look at it, who's using ARC, who's using HC, the home-based community care. But for us to estimate that balance, we need that estimate of when they transition into ARC. So,
and to answer the question of what predicts admission, you have to be able to accurately identify the admission to long-term care.
So often in studies, we say, what are the predictors of ARC, without looking at whether they were transitioning from what type of care into.
Right. And it's my understanding correct that it's probably easier to identify the moving into ARC, but the more difficult issue is that when they move out.
So it's going to be the same. So this one is at the entry level, right? So each assessment will have either an in-ARC, possibly in-ARC, possibly in community, and in community. But when we string them together, look at number 2. If we string them together, we can tell whether they're in ARC all throughout, they're already in ARC, and then they can switch back into community. So this was an interesting bit for us, that we found people who were returning to community after a substantial period of time spent in ARC. And then you've also got that from community going into ARC. So it's just that point of telling at what point did they move into ARC, so we can estimate the balance of care that they're getting.
Did you count being in hospital as being in community?
So they're in hospital. So this is why we have that 10% I was saying, around 10% that we can't tell if they're in ARC or in the community, because the assessment was made in the hospital. Yeah.
John.
Thanks. So we have a series of papers we've published from previous grants using multi-state transition models in long-term care home settings, which is the ARC equivalent. And what we do with those is we simultaneously model transitions in health status for people who stay in the facilities, as well as transitions to a hospital, mortality, discharge home, and transfer to other facilities, all in the same model.
Right.
And that gives you sort of the simultaneous view of all the things that are going on. There are predictors for who will be discharged back to the community from a facility. Brand Fries did some early work a couple of years ago that sort of focused on people discharged in U.S. homes to the community. They tended to be younger people with disabilities. During COVID, we found there were people being transferred back to home as family members were worried about COVID. The other thing is that we found a temporal effect, so that within the first 90 days of stay, a lot happens. People get sicker, people get better, people die, they go to hospital, and they go home. Once you're into 270 days or more of the stay, the probability of going home drops precipitously. So for several of you may want to explore the potential of these multi-state models, which allow you to deal with mortality and hospitalization as absorbing states, but also let you do the dynamic transitions in health states over time.
Yeah, definitely. So this is our idea for the descriptive part, and we'll move on to multi-state modeling once we've done this part. Yeah.
We still have 5 minutes. It's tricky because we don't really want to start too early in case people are timing their return to the room. I have a question.
Yeah.
So, Leah, there's supposed to be a date of admission in the data. What's wrong with that? Is the actual date of admission?
The date of admission is not recorded in the IDI.
Oh,
we don't.
The IDI.
Nah.
Why not?
It is in the LCCF. No, it's not a variable that's coded within the IDI. So, yes.
So they must take some information out of the long-term care before they put it in the IDI?
Yes, yeah. I think so. So
yeah.
This is why because if you had a date of admission, then I mean, why would we do that, right?
So it could be privacy officers injecting themselves because you know what we find in Canada, as soon as I try to do a record linkage among too many records, it gets run through a re-identification risk algorithm by CAI, and they hate date variables like that because of potential re-identification risk. So that may be what's going on.
That's maybe a dumb question.
Here you go.
But how do you, I see there's like, I know it's such a complex pathway, but like, what is the actual definition? Like, I was thinking about the transition period, but the definition of residing in residential care. Like, what is your definition for that?
Having an LTCF.
Say it again.
How do you define it?
Yeah. So someone would be on publicly funded respite, paid for by the government, and then when that switches over to the person paying, that's the date of entry, right? It'll be based on financials, I would expect, or when the government starts paying the residential care subsidy. That would be your date of entry on paper, but it might not be your physical date because you might have been there on respite.
So we're trying to get the physical date.
Yeah.
So when you actually go
physically go, even if it's respite care, because that won't change.
We'll have some determinants. For example, we did another NIRI in our other study. We did a 90-day, like if you're there for 90 days, then it's not. No, it's not ARC. It's
Oh, hey, I'm from the Te Whatuhora's National Aging Well team, and we're looking at this particular thing because it depends on the source that's getting the data. And so in some surveys, it's the date that your entry, if we're paying for you or not. If you're self-funded, that's the date that you start. Or if you're in respite care and then you come back out, that's one date. And then we also capture a funding date. So we're capturing a lot of different dates right now, and we're actually working on how do we consolidate those into a single national way of calculating that.
Yeah. But that's really cool because you have all the payment data sets. Yeah.
Well, wait a second though. I've always been troubled because Te Whatuora and Ministry of Health both report by the CCRP, by the payment dates, but there is a solid about 30 to 50% of rest home level people who have no payment. That's right. And so we really have to rely on the LTCF data to identify them.
And we have two different surveys, one from the Eldernet that is reported by providers that is done on a daily basis. And then we have another quarterly survey that providers provide us an information, but we're relying on them to tell us that information, interpreting what the start date actually is. From different,
Do they report by individual level data?
They have yes, they do, and for Eldernet and for the quarterly survey and things like that. Yeah.
Okay.
Yeah.
Okay. So Gary is a comment. Yeah.
People may have the answers. Like you, Nari, I rely on the LTCF to define ARC emissions. So do we know out of people living in ARC but not having an LTCF?
It's not supposed to be allowed, but I know that it happens.
Does it happen?
At an aggregate level, not down.
It'll be good just to find that out, isn't it? That wouldn't be too hard to do because we can go, but go into a facility and look at how many of the residents have no LTCF. You can get that.
So we had the Staying Upright trial, which was 850 people in long-term care, and 180 of them had no record of any LTCF. And so we don't know how that happened. Karen, how do you think it happened?
Depends on the facility because they are required to do an assessment. If they are getting a subsidy, then they do the LTCF and they do that religiously. If someone is being self-funded, then often a facility, if they're pushed for time and if they have low assessor rates in their home, then often that's missed because they aren't required to for those who self-fund. And the threshold's quite low. So especially our North Auckland people, our Tauranga people, they've got quite a lot of cash up before they end up getting a subsidy.
So the change of address method is actually when a person changes an address from your usual address to an address where a large group of people live, that's actually their signal. So maybe combining the change of address with the LTCF is one way for us to tell if people, even if people don't have that LTCF, but they do have the change into an address where a large group of older people are living, then we can maybe.
That could be a retirement village, my dear, and that's
That's
not
right.
ARC. Yes.
Just one
Okay,
big-
there's one comment up here which we can all read about the limitation of the LTCF admission date being related to software. Thank you very much, Ashley, for that. And Tim, is it a question or a comment?
comment, but just have you considered? I guess I'm thinking of some of the work that I saw done by the Human Rights Commission a few years ago around looking at older people in age residential care and whether they actually had EPOAs on file or not. And so they actually went in and they did an audit of, I think, 6 or 8 sites and quite revealing results. And so whether there's actually a room for some work to happen alongside this to actually do a real world engaged, like site-based analysis. And then that would probably be quite interesting, I'd say.
I don't want to get anyone in trouble, Tim. That's my objective. It's all in the state of quality. So thank you very much,
Thanks,
Leah.
everyone.
Excellent discussion, everybody. Thank you.